Okay, good afternoon, everyone. My name is Councillor Lily Bath. I'm the Deputy Leader of the Council, and I'm going to be chairing the Hounslow Health and Wellbeing Board. And I have to give my apologies for Councillor Candice Atherton, who would normally be chairing the board, but unfortunately she's not going to be with us today, so I will be taking her place. So welcome all, and as you know, we, as part of the government regulations which passed in 2020, we are able to hold virtual meetings, and that's why we have a Health and Wellbeing Board which is going to be virtual today. So thank you everybody for coming along and taking part. Just to remind you, and I'm sure that you already know, that obviously we are operating virtually. So if you could have your mics switched off and muted, then that would be really helpful. I've actually got myself, I've got my camera switched off because I'm having problems with internet, and it just makes it slightly easier for us in terms of conducting the meeting. So we usually have quite a few members at board meetings, and it gets a little bit difficult, obviously, to introduce each other. So what I propose to do is that when somebody wishes to speak, if they could then introduce themselves then it would make it a lot easier in terms of running the meeting. So I hope that's okay with everybody. Can I also check that you're all muted, and remind members of the public that the agenda and all the reports that are being considered by the board this evening can be found on the council website under the Hounslow Health and Wellbeing Board meetings page. So you should be able to find everything that is here on the council website. Can I also ask members to remain present for the whole of the discussion, and please don't walk away, because if we come to a vote, then it is a legal requirement that you are present for the whole of the debate, otherwise you won't be able to vote on it. So appreciate your cooperation on that. If you find you are having technical problems and need to log out of the meeting, come back in again, could you please let me know so that I'm aware that there was a slight interruption and you were not part of that meeting, if that is necessary. So can I say thank you everybody for joining today, and I will then move on to apologies. Obviously apologies for Councillor Atherton, and I'll be chairing for her. Do we have any other apologies for absence?
Thank you, Chair. Kay here, the clerk. We have apologies from Annabelle Crowe from the CCG. I think Mark Jarvis is attending here, and also Martin Waddington in her stead. Susan Rooston from the CCG has moved now to Hammersmith and Fulham. So okay. Again, congratulations to Martin. He's now standing as acting managing director for the CCG. Leslie Watts has given her apologies. Mark Titcombe from West Middlesex Hospital is here in her stead. Carolyn Regan from West London NHS Trust is deputised here by Sarah Rushton. Patricia Wright from HRCH, Hounslow and Richmond Community Healthcare, is succeeded by Anne Stratton, because I believe that Patricia has also moved roles. Just a few more, actually, bear with me. Chief Superintendent Peter Gardner is not here, but he's deputised by Superintendent Sharon Brooks at this meeting. Toby Kempton from the Fire Brigade is deputised by Jerome Kumadzina. And we have two new members, Chair. We have Toby Cray, who's our VCS representative, and Dr. Akil Mayer, who's from the GP Consortium from this meeting onwards. Thank you, Chair.
Thank you very much. That's excellent, and welcome to new members. So if we move on to the next item, agenda item 2, where we will be looking at the minutes of the last board meeting, which were held on the 4th of November. I just want to take accuracy and matters arising together, if that's okay. Can people let me know if they have any accuracy, or is there any all matters arising? If we can do that together, that would be helpful. I can't see any hands up or.
Thank you, Chair. Are they agreed?
Yeah. Are there any actions, anything that's arising from the minutes from last meeting?
I don't believe so. I think Kelly had mentioned in the last meeting that she was going to take the terms of reference to this one, which she has.
Right, okay. In that case, sorry, I'm just switching between screens in case you're wondering I've gone. Okay, thank you then. So obviously I don't have a physical copy, but if you're happy, I'm happy to sign those off if that's okay with everybody. Okay, so we now move on to agenda item 3, sorry, not 8. For some reason, I've read 3 as 8. So this is going to be Kelly O'Neill, who is our Director of Public Health. And Kelly has a presentation to the board, and it's really for the update. And what I will ask then is for board members to ask any questions or make any comments off the update. Also a reminder to let you know that you can obviously use the chat facility if you wish to speak, or I think you can also put your hand up as well. Where there is a hand function as well. Okay, so Kelly, is that okay? Are you ready to move on to your presentation?
Yes, thank you, Councillor Bath, and good afternoon to everybody. I'm going to do an update on the impact of COVID on the borough and use some examples of some of information that we have available to us. I'm going to be joined in this update by Sam Greehey, who is one of my public health officers who deals with geospatial information, and also by Sterling Rippey, who is our public health strategist for insight into behaviour. It is going to be very much a team approach to this. So let me start by sort of explaining what we're going to do here. So as we have gone through the pandemic, through the first wave, and now into quite far into the second wave, what we have started to develop is a much better use of data. During the first wave, we had very, very little data in which to inform some of our planning, and so much of our response was based on anecdote and looking at information that was available, but the validity of it was pretty poor. But as the pandemic has progressed and we've started to develop much more systematic ways of accessing data and using it to inform our decision makings, we've been able to be much more intelligent about the way that we operate. So this particular presentation is going to tell us about to demonstrate what the data tells us. We'll look at the big picture for London, the local picture for Hounslow. What is very, very clear from this presentation is that there is significant variation across the borough in terms of the impact of COVID on cases and on deaths. And we're going to use geography to sort of identify where there have been communities more at risk. We're going to look briefly at health and social inequalities, and obviously that's going to be key moving forward because that is the basis of our recovery plan. We're going to look briefly, or Sterling's going to take you briefly through communications and engagement, and we're going to look at our current priorities, our system leadership, our demand management, and our testing and vaccination. And with our vaccination, Ellie Tobin, who works in joint commissioning, who is working across the CCG and the council to support the rollout of the vaccination plan, will join us to present some of her slides. So next slide, please. So data comes in various different formats. So if you look at this particular slide, you'll recognise this as a picture of London, and this is our infection rate per 100,000 population for the London boroughs, and it's information from the 1st of February. So what you'll see is Hounslow has a rate of 432 per 100,000 population. The darker the purple, the higher the rate of infection. And what this demonstrates is that you'll see in northwest London, rates of infection are currently the highest across the city. And what we've seen is a a ripple effect, a sort of a wave of infection spread moving from East London and directly over to West London, which is, essentially what we're seeing now is a very delayed impact of this current lockdown, and some rather difficult rates of infection that are coming down at a very slow rate. Now, the importance of why high rates are of a concern is that high rates lead to high numbers of people being infected, and lots of people being infected means a significant demand on healthcare, particularly on hospital care. So the quicker we can bring down the rates, albeit that there will be a lag in the impact on hospitals, the fewer people are likely to access hospital care going forward. So this kind of challenge of a very slow decline of rates is a real concern at the moment. Next slide, please. So this is a pandemic curve of our rates of infection. So this is the start of the sort of infection journey. So what happens is essentially is that people are exposed to infection, and a few days later, they will go and get tested, and this is what this bar chart and this curve is. So each of those bars is a day of infection, and the number of cases on that particular day, and the dark blue line is a rolling 7-day rate of infection. Now, as I said previously, when I've used this particular chart, the small curve on the left-hand side between March and May were cases that were hospitalized cases. At that time, the only people that were being tested were those people who were seriously unwell and were being admitted to hospital. So therefore, understanding how big that peak, that size of that of the numbers of people being infected is unknown at this moment in time. But as we've gone through the months towards sort of June and July time, we have started developing the capacity for initially key worker testing, and then moving to sort of mass testing in the community. Particularly focusing on people who are symptomatic. Now, obviously, around about September time, there was a lot of media focus on the fact that capacity for testing wasn't as high as it needed to be. So I think there is probably around about September, October time, it's probably an artificial recording of the numbers of people that were testing positive due to the finite capacity we saw in London, particularly as a lot of the capacity that we'd had previously had in London was being diverted to the northwest and the northeast, where there were much more significant numbers of infection. On the back of that, at the beginning of September, obviously schools went back after a period of being absent for a long period of time, and then you start seeing this increase in rates of infection. Now, the issue that we've had in Hounslow, and it's not something that I can explain particularly, other than to say it is probably likely to be a combination of factors, probably mostly social and economic, is that the impact of lockdown doesn't appear to have had quite such an effect compared to more affluent boroughs. So what we have clearly seen in London is that North London boroughs, particularly outer London boroughs, where we have a significant number of key workers and people who are legitimately moving around the borough in lockdown, has meant that the rates of infection haven't gone down as quickly during a lockdown period as we would have liked to. And certainly in that sort of lockdown 2, lockdown light, what we saw is a very small effect. And then suddenly lockdown was over, and we suddenly saw this massive increase in cases in a very, very rapid period of time. So I've put some reference points onto this graph just to demonstrate how quickly the increase in cases occurred. So if you look back at the 12th of December, we had a rate of 171 per 100,000 population. By the time we get to the 12th of January, we're looking at a rate of 1,141 per 100,000. And the biggest, most significant increase we've seen is between it is the impact of Christmas and New Year combined, which will have contributed to that 12th of January total. And once we've reached that peak, we've seen a decline that has been relatively slow. In other boroughs, the decline has been very rapid. So by the 26th of January, we're at a rate of 645 per 100,000. 27th, a rate of 596. And the next slide, when we go to in a second, we'll show where we currently are. So if you look at the 12th of January, just for comparable figures, a rate of 1,141 meant that 3,098 people tested positive in that previous 7 days, of which 445 were over the age of 60. Now that's important because age is the most significant single risk factor to whether someone is hospitalized and whether someone has really serious complications and dies. There are certainly people that fall outside of that age profile, but the majority of cases will still exist in that older age bracket. Over 60s have consistently accounted for between 13 and 15% of the overall figures every single week. So there's still a too high a number of older people becoming infected. And there are a number of explanations, and we'll explain what our theories are on that from the data that we've seen. Now, on the 12th of January, we're seeing a case positivity rate of 23%. That means 23 out of every 100 people being tested was testing positive. That is a really high number. So our testing rates is roughly between about 13 and 14,000 tests per week that we currently do. So the fact that there's 23% would indicate that we're not detecting everybody in our borough who is positive. Now, we know 1 in 3 people are asymptomatic, so they don't know they've got coronavirus. We know that even though they're asymptomatic, they are still infectious. So a lot of people are still moving around the borough, either not knowing that they're infected or knowing and choosing not to get tested. Ideally, that case positivity rate needs to be around about 5%. In order for us to be assured that we're capturing as many cases as we possibly can and identifying those cases. And the important thing is once we identify those cases, we then follow them up and ensure that they are isolating. So we move to the 1st of February. So our case positivity rate is 432 per 100,000. That means 1,172 people tested positive in the last 7 days. That again is 170 people over the age of 60. Again, that's roughly about 14-15%. And really importantly, our case positivity has come down to 9.4%. I think London at the moment is roughly about 7%. But again, we're aiming to get that figure down to 5%. And that means that we have to test more and more people. The more people we can test, the better, because that gives us an overall picture of what the what's happening in the epidemiology of the disease in the population and what the community transmission looks like. Between December and January, and I sort of omitted to put the deaths in for January. So the number of cases, number of deaths that we had in December was 53. The number that we've had in January, I think, is about 184 deaths. That I'll look at the next slide. I might be able to remember what that figure is. But what we have seen, I mean, that is a massive increase in the number of people that have died during January. And this is directly as a result of this significant increase in rate of infection, the number of people that have tested positive during the month. We'll know that figure probably in about a week's time when all of those deaths have been recorded. Next slide, please. Sam, do you want to sort of step in now?
Yep, sure thing. Thanks, Kelly. So hi, everyone. I'm a public health officer as part of the public health team that sits underneath. I sit underneath Kelly, and essentially this is just displaying a map of Hounslow and the total number of cases across the entirety of the pandemic, and which areas we've seen the highest number of cases and the burden where it's greatest. So similar to the London infection rates map, the wards where we're seeing the darkest purple represents the areas which have had the highest number of cases, And as you can see, the darkest areas are certainly within the central and western areas of the boroughs. So particularly Hounslow Central, Hounslow West, Heston West, but then also Hounslow Heath, Heston Central, Heston East and Cranford have been particularly high performing in terms of case numbers. And you can also see there's sort of a polar contrast in the terms of the numbers of COVID cases in the east of the borough in Chiswick specifically. So just to sort of gauge a sense of the recent increase that was shown in the pandemic curve that Kelly displayed on the second slide. Just in terms of total number of cases we'd seen in Hounslow from the 20th of December, we had reported 8,373. Now in just over a month's time, up to the 29th of January, which is the information we used from the 1st of February, we had recorded 21,643 cases, which equates to about a 158% increase. So in a very, very short period of time, we've seen a drastic increase and just shows how the picture has changed considerably. In terms of the age profile of cases, like as similar to Kelly mentioned, the age profile, we've seen the bulk of cases being within the working age population, equates to about 70%. And we've been monitoring sort of a 15% totality number of the over 60s and under 19s. And as Kelly mentioned, the weekly rates of and numbers of cases over the age of 60 sort of fluctuates each week between 13 to 15%. Sorry. Next slide, please, Andrew. Thank you. This is just displaying the infection rates within each ward per 10,000 as opposed to 100,000. So when we report on Hounslow's position, we primarily focus on how it's performing as a whole, but obviously within the borough itself, different wards have different size populations. And so what this enables us to see is which areas have had the highest number of cases in comparison to and in context with their size of population. So one thing to sort of consider here is despite Hounslow Central having considerably the highest number of cases in the borough across the entirety of the pandemic, it's less high in terms of infection rate. As you can see, it's only 823 cases per 10,000 population, which essentially means Hounslow Central has had the highest number of has the highest population within the borough. Therefore, if you look at it in comparison to the rest of areas where population size is less great, it's less affected. Therefore, Heston West and Heston East and Cranford are areas where the population size is less great. The impact is considered greater there. Next slide, please, Andrew. Thank you. So this is the previous 7 days reporting using yesterday's data. And again, the general trend matches the overall pattern. Whilst the numbers are considerably smaller in comparison to a couple of weeks back, and certainly at some of the earlier area forums that Kelly and I presented at, we're still seeing the highest number of cases within the sort of centre and west of the borough, predominantly Hounslow Central, Hounslow West and Hounslow Heath, as well as Heston West. And again, sort of the general pattern of Chiswick performing far at the bottom end of the scale in terms of number of cases. But one thing that's key to note with when the infection rate is reducing, the distribution tends to be quite unequal and it's relatively sporadic because different areas will have recorded cases at different rates. So therefore, when they fall off the end of the 7-day reporting date, it tends to make reporting and monitoring is quite difficult because the position often changes quite frequently. Next slide, please. Thank you. So this is a hotspot map, and essentially this helps measure the proximity of cases, and it enables us to consider and look at where areas are seeing the highest number of cases within each ward, as opposed to looking at the ward as a whole. And so what this is really effective for, and what we have been using these maps for, is being able to target resources and in terms of support and providing extra information to the community. So for example, we can prioritise sending specific communications to areas where we're seeing the greatest clusters of cases, but then also we have been sort of using this to inform with engagement as well, but then targeting enforcement and certainly COVID patrols and sending the marshals and site visits to areas where we've seen the highest number of cases and where clusters are greatest as well. We're also sort of developing and using this in terms of potentially analysing, assessing where we could use future mobile testing units and testing sites as a whole. Next slide, please, Andrew. Thank you. And then this is just essentially going back to a couple of slides before where I showed the infection rate between wards. If we look at the infection rate within wards here for the last 7 days, again, considering the population sizes, you can see the impact is felt greatest in sort of in similar areas, but also it highlights different areas as well where the population size may be smaller, so the impact is greatest. So again, Hounslow Central, despite having the highest number of cases within the last 7 days, the impact of the infection rate is lower in comparison to Heston West, Cranford, Hounslow West and Hounslow Heath as well. Next slide, please, Andrew. Thank you. So some of the work that our intelligence team has done is using indicators and factors that were identified in the Public Health England Disparities Report last year, which may have contributed to explaining why certain areas and certain populations have been experienced and affected by COVID to a greater level. So some of these factors include sort of geography, but also demography, such as age, ethnicity as well. But then there's also sort of wider determinants of health, such as education, employment, financial stability, and income as well. So essentially what the intelligence team have tried to do, they've tried to use this information and use data sets where factors such as these are considered, and hopefully and attempting to apply this to Hounslow just to see if there are any correlations as well. But just a couple of disclaimers. Some of these data sets that we've tried to sort of incorporate and generate these correlations and relationships, they are often quite incomplete. And they also, some of them that we've had to use have come from the census 2011, so it's slightly outdated as well, but nonetheless, it's still useful to have that sense of information. Next slide, please, Andrew. So the first one here, so this is considering the rate of COVID-19 cases per 10,000 compared with the population density of each wards. And so just generally, what we've been able to see is that those wards with a higher population density, such as Hounslow Central, Hounslow West, Heston Central, Hounslow South and Heston East, essentially they are the areas where we've had high population density, but also where we've seen the greatest number of COVID-19 cases. Although the correlation is relatively weak, again, it's indicative of the greater population density, the higher number of COVID-19 cases. Next slide, please, Andrew. In terms of just impact generally, so as I mentioned before on the map of general cases across the borough, the general age profile that we've seen, predominantly the majority of cases have been within this working age population of 20 to 59. But if we tailor that to factor in the most specific age profile, as you can see from the graph, it's between the ages of 31 to 45. And again, this is sort of expected and representative, because if we consider the age profiles of each ward, the population size and age size that is greatest across the entirety of the borough is between this 31 to 45 age group. So again, it's sort of representation of what we can see within the borough. But as Kelly mentioned beforehand, the risk is exacerbated by the age of the population of those who are affected by COVID. Next slide, please, Andrew. So in terms of deprivation, so this, again, another correlation graph here for you. Apologies, there's quite a few graphs coming up. Again, this is looking at the level of deprivation at ward level and then comparing it to the rate of COVID-19 cases within each ward. And what you can see here is that wards that are less deprived, so such as Chiswick, Tanning Green, Chiswick Homefields and Osterley, the wards that are less deprived have seen a lower number of cases, and then in comparison to the more deprived wards such as Heston West, Cranford, Feltham and Brentford, we've seen a greater number, as well as Hounslow Central and Heston as well. But what we have done as well, this is just at ward level, but this can be sort of broken down into more localized geographical areas, such as lower super output areas. So as opposed to just assuming that each ward has a certain level of deprivation, because the difficulty with this, it's called ecological fallacy, is that assuming that every area or every region of particular wards have the same level of deprivation. This obviously isn't true. Different areas and different parts will have that. So that's why assessing this at LSOA level is greatly impactful and can provide more localized and deeper insight. Next slide, please, Andrew. Thank you. So this is just a general slide about how social and economic differences within and the impact of these within the borough and how it's been exacerbated by COVID. As you all know, obviously the proximity to Heathrow, the size of the population that are employed by Heathrow, this has been a big factor, as well as the leisure sector and the hospitality sector. And what we can see essentially is that those areas that have been more adversely affected by the furlough scheme and those being put out of work, that's been sort of again, because of the proximity to Heathrow, it's affected the west of the borough more generally. And essentially what this is just showing, I won't go into too much detail with the information, but essentially what this is showing is that those who have been impacted by furlough and COVID as a whole have also is notably within the areas that have been where levels of furlough are greatest, and also the level of universal credit applications is greatest as well. So the most disadvantaged have become even more disadvantaged due to COVID-19. Essentially, this is what that slide is showing. Next slide, please, Andrew. Thank you. Looking at the ethnicity and the population dynamics, what this correlation is showing is that wards with the higher BAME population, more diverse populations, have seen a higher proportion of positive cases. So the more demographically diverse, the more cases have been shown. Again, you could break this down into LSOA level, so lower super output areas, to get a more localized, specific understanding of each area. This is work that probably is ongoing and will certainly generate sort of some useful feedback just to gauge greater insight and being able to be more specific. Next slide, please, Andrew. And then if we considered, for example, the Asian population group, specifically Indian and Pakistani, the correlation is, so the wards with the high proportion of Asian groups also have a higher rate of positive cases, as shown from the entirety of the pandemic. Next slide, please, Andrew. So in terms of multi-generational housing, so this is one of the big things and big factors as to why COVID-19 cases have been quite high within Hounslow, as you can see, and certainly within the areas where COVID-19 numbers are highest. So as you can see from the left, where the numbers of multi and intergenerational housing is greatest are within Hounslow Central, Hounslow West, Hounslow Heath, Cranford, Heston East and Heston Central. And as you'll have seen from the graphs and the maps that I've shown, those are the areas which have been affected greatest by COVID numbers. And certainly what we've seen when we look at the daily line listing that Public Health England sends to us, what we can really see, and what the next slide will also cover as well, is that the highest number of what we see greatly each day is that there are significantly high numbers of cases that come from the same household, which again is this indicative of intergenerational household spread. And it's just coincides slightly with the fact that the highest number of intergenerational housing is within the areas where case numbers have been highest. Next slide, please, Andrew. Thank you. So this map here is displaying the level of overcrowding within the borough, which is provided in the Hounslow Insight. Whilst it's quite difficult to gauge, essentially, if we looked at the raw figures, overcrowding again is highest in Hounslow Central, Hounslow Heath and Hounslow West. And as I mentioned before on the slide previously, the areas of which we've seen obviously cases highest has been within those wards as well. And again, it's sort of this representation of intergenerational households and cases being found within the same household spread. Next slide, please, Andrew. Thank you. So this is a different concept and different way of considering it. So English not being the first language, and comparing the correlation between the rate of cases and English not being a first language. So again, wards with the highest proportion of those that do not consider English as their first language, and the highest number of cases. Again, the pattern is emerging where the correlation is strongest is within the Heston and Cranford and Hounslow Central wards. But one thing to sort of consider with this is, and one element to consider is the element from communications. So having a diverse population, obviously English not being the primary language for a lot of the population, there could be the consideration there have been communication barriers, certainly with some of the information that we have maybe been providing. But something that I know Sterling will be considering and speaking about in the next couple of slides is the work that's going on to engage with community and those that are hardest to reach, but also the work that's going on with translation and engaging with our community champions as well. So next slide, please, Andrew. And then the final slide for me is considering poor health by ethnicity. And essentially, in short, what this correlation graph is showing is that if we are factoring in pre-existing health conditions amongst our different populations, if we consider BAME and white communities, BAME communities are still worse off even in terms of COVID impact, even if our white groups and white areas of the borough, sort of in the Chiswick area, even if they have pre-existing conditions, they still have been affected less by COVID in comparison to the BAME communities. And the next slide, please, Andrew. Okay, that's back to you, Kelly. Thank you.
Okay, thanks, Sam. Excuse me. I'm just going to go through a series of slides that just sets out deaths. So apologies, I'm going to do it in purely public health terms here. So in terms of a population of people who have died in the borough. Excuse me.
Kelly, do you want to? Are you okay? Are you okay?
Yeah, I'm fine.
30 seconds. It's awful.
I think I've just scalped Councillor Bath. Yeah. So no, I'm fine. I'm fine. So this is Office of National Statistics data. So there is a lag, as Sam says. Every time we use Office of National Statistics data, it's about 2 to 3 months lag in information. But that is the most comprehensive data set that we have. So what we are looking at here is information from January until the 30th of November. Now that accounted for 245 deaths in the borough. Obviously, as we've gone through this second peak, that's when a significant increase in deaths has occurred. But we don't have the granular detail behind that in order to really understand what was the demographics of the people that have died within our borough. Also, as part of this, there is a smaller number of people, up to about 30, I think it says on the side, 36 people where the ethnicity is stated as unknown. So, the data set isn't always complete. Okay. So what we've seen is that our Asian community accounts for the highest number of deaths, and even when you put that into sort of population, the rate per 100,000 allows us to compare different population groups. So obviously our population size is different based on different ethnicity groups, but actually having a rate allows us to see that difference. So our Asian community accounted for a rate of 96.8 per 100,000. Now, if you look at the other groups, our Black community is a much, much smaller community, but again, it really features very highly in terms of rate of infection, and obviously our majority population being white, it accounts for 72.7. So there is some real differences when you take out the actual numbers and apply them to how proportionate it is to the population. You can see some health differences or some adverse outcomes, death differences based on the data that we currently have. Next slide, please. Now this is data, and I'll explain these tables. So this is data, this is our own data up to the 31st of January. So this is data that's available on public sites. Okay, so we're not sharing anything that the general public doesn't have access to. Now, if we look on the left-hand side, the pandemic curve of deaths. Now, we didn't know during that first wave what the true number of people getting infected were, but by using death registrations and where it states COVID on death certificates, we are able to see that there was quite a significant number of people who did die up to around about sort of March and April time within our borough. But as we moved into the second wave, there's been a significant increase in the number of deaths, particularly sort of in January time, which you'll see on the right hand side of that graph. Now, in comparison, there's just some bullet points here that shows where our rate of death, where we are in comparison to other areas. Now, in London, after the first wave, we had the lowest number of excess deaths. Now, when we look at excess deaths, this is where you apply what would be the usual number or the usual rate of death in a particular area, which is kind of averaged over a few years. So that gives us an idea what the normal level of deaths that we see seasonally and every year, and we smooth that out. So when you're looking at excess deaths, it's over and above the deaths that you would expect within an area given our current situation. So in the UK, The COVID rate of death is 159 per 100,000 population. In England, it's 166 per 100,000 population. In London, it's 150 per 100,000 population, and that is because London has a relatively young population, and in Hounslow, we're at 168 per 100,000 population. And what you'll see is quite significant differences between inner London and outer London, and those differences will be based on sort of the age profile within different boroughs. But saying that, if you look on the right hand side, what you'll see is, and it's a bit blurry, I'm afraid. The yellow dot that you see, so the red line is the England average in terms of rate. So it's yeah, I think, yeah, it's 166 per 100,000. The yellow dot is Hounslow, just slightly above. You can just about see it. Now, if you look on those kind of right hand side, the sort of the ones that are clear outliers, those are either cities or counties. So this is just based on numbers. So it's not comparable, because obviously counties and cities, when you count them together, have significantly higher numbers because they've got much bigger population. So this can only account for numbers, but obviously if you look down those sort of on the right hand side, what you'll see is just an amalgamation of boroughs that's similar to our own. And at the moment we can't see any significant difference over and above other areas, apart from on the very extreme of the left hand side, you'll see those areas such as, you know, Orkney, Rutland, Cornwall, areas where the population density is not as significant as what you would find in very urban areas such as London boroughs. Next slide, please. So this is another cut of the data from that 245 cases that we had up to November. And this looks at people who died prematurely, people under the age of 65 who had no pre-existing long-term condition, and looks at what that rate is for people where there was no indication of any comorbidity that would have been a significant risk factor. And some of the work that we have been looking at, particularly in the integrated care partnership, as part of the rising risk work stream that looks at, you know, that this particular sort of work stream of indicators to try and sort of what interventions can we put in place, how do we work with different communities in order to reduce their risk in general. The Black community, which is a small community, is very much overrepresented in this kind of under 65 group with no previous long-term conditions. So work is already going on to address part of that. But obviously, as you see, as we build up this data set and as we get more information, and when we do get the proper ONS data, that will be able to bring us to where we are, around about 445 deaths so far across the borough in total, we'll be able to have a much better picture of where we need to target. At the moment, we are working on this kind of semi data set, but a semi data set allows us to start taking those steps forward and start to try and work with communities where we can start, where we have seen that there are significant risk factors. Next slide, please. Now, this is deaths per ethnicity, by ethnic group, of people who had pre-existing long-term conditions. Now, we know age is the single biggest risk factor, but we also know that if people had certain long-term conditions, they also were at greater risk of dying. And again, much like the sort of the correlation graph that was presented previously by Sam, is that the Asian population is overrepresented in the people who were getting infected, but equally they're overrepresented in those people with long-term conditions who have died. So that's essentially just a different way of looking at it, obviously from a different outcome perspective. Next slide, please. And when we look at the comorbidities, what the majority of people who had long-term conditions died of. This is a funnel plot graph which just indicates which is the highest number. So 97 people died from with a pre-existing condition of having high blood pressure. 64 died of cardiovascular disease, and 58 died with diabetes. And obviously there's been a sort of a lot of media that's been focused on diabetes being a significant risk factor. And I think sort of the public health line, the public media line was 30% of people with diabetes. 30% of people who died had diabetes. And then you go down to chronic kidney disease, obesity, stroke, and all of those kind of other risk factors that we've seen played out in the media. Where there is has been a significant number of deaths, and obviously in some of those sort of older groups, particularly with dementia, that also includes people in care homes as well. Next slide, please. And then we look at the three top condition, the three highest number of conditions of hypertension, diabetes, and cardiovascular disease. If you then cut it by ethnicity, again, you'll see the sort of overrepresentation of the Asian population, with the white British population also being adversely affected. We know that diabetes is more common in Asian communities, so that probably accounts for why you see it less of an indicator for the white British community. But again, if you had a pre-existing condition, you were significantly at greater risk of an adverse outcome from COVID. You were more likely to be hospitalized. You were, as a result, sort of consequently, you are more at risk of dying, or continue to be. So next slide, please. So in terms of what we're doing then, so that's the data set. That's the information that's being generated. It's not, as Sam said, it's not complete, and we're constantly adding to the information. It's very, very dynamic at the moment. And as we build up this information, we're able to make much better use of it in order to use it as part of the integrated care partnership programs, and also to target many of the interventions that we're currently prioritizing. So in terms of our system management, and this is being led by many people who are on the meeting this afternoon, it allows us to try and prevent and intervene early. So Sam says, as we use data and intelligence, it allows us to inform some of our actions. Rather than take a very blanket approach, we're able to target different communities who are at greater risk, who the data tells where the data tells us that the biggest burden of infection is, where the biggest adverse outcome exists, and where those target communities who are most at risk for this are living. It allows us to warn and inform, and I'll leave Sterling to talk about messaging and interventions, and I'll leave her to talk about engaging community as well. And I have to say that as we have progressed through this pandemic, certainly as we've moved into the second wave, we started to engage much more successfully with communities and building community champions. But I'm stealing Sterling's thunder, so I'll leave her to deal with that. Now, the other thing that we've done much more effectively is having to respond to escalation of cases. Now, during the first wave, I think it is fair to say that it was a bit of an all hands on deck within the community. But actually, as we've moved into the second wave, we've had a much more coordinated approach to outbreak control. We've got a full standard operating procedure for responding to outbreaks, whether they're being care homes. We've HRCH is supporting us, as our general practitioners are also supporting us in being able to more effectively manage outbreaks in care homes. I would hasten to add that we have seen a significant increase in the number of outbreaks that we've had in care homes, especially in relation to this Kent variation of COVID, which has been much more transmissible. So by the time we've identified some cases, we know that the next round of testing is likely to reveal some more. So it's been an ongoing battle to just get on top of these cases. Care homes have been outstanding in the way that they have been incredibly resilient, dealing with this ongoing case finding, ongoing contact tracing, and ongoing care of their residents. In addition, schools have played a significant role, and I would take my hat off to my colleagues and head teachers in schools. They have become true public health officers. Their ability to contact trace within their classrooms and within their schools is second to none. They have systematically, 7 days a week, just identified, contacts of cases. They have put people in isolation. They have had to deal with a significant number of issues over and above running the school, as they were previously. And given that we still have a high number of children of key workers within our schools, albeit at a lower level in terms of numbers, they are still responding to emerging cases of infection. On top of that as well, businesses are not excluded. We have environmental health officers who are constantly dealing with our high priority businesses and also following up businesses where our data from Public Health England tells us that there are links between cases, and that common setting is a business within our community. And our absolute priority is to protect the most vulnerable throughout all of this. So once we've identified cases, and obviously we've got testing, quite a lot of testing going on in the borough, I'd like to see more. We've got a large number of symptomatic test sites. This is at Twickenham and at Heathrow, at Bell Road, Padstow Walk, and Barabazon, I never can say that, Barabazon Way. Those are our testing sites that the Department of Health and Social Care have allowed us to put in the borough. We're allowed to move them where we need to move them, and we've got a new one that's come online in Chiswick, and we move them. They're quite difficult to move, so despite the fact that they're meant to be mobile, but we move them and place them in areas where the infection rates have consistently been higher. On top of that, we have set up a number of asymptomatic, these lateral flow rapid testing sites within our borough. Again, we've tried to locate them in areas where the rates are higher. So, for example, we have one at Heston Library that addresses sort of the Heston area because of the high rates there. We have one at Hounslow House, again, central Hounslow, have had higher numbers. We have one in Isleworth Library. We've just opened one in Staines Rugby Club because of the high numbers of cases that we had started to see in the Bedford and Feltham area. And we have roving mobile units that go to areas, particularly businesses, where we see large numbers. So where we have seen large number of cases, but also as a means to protect key workers, so ongoing surveillance of cases. Also, we have enhanced contact tracing. So what happens after someone tests positive is that the national team will contact those individuals, and subsequent to that, where those people aren't contactable, and some people choose not to be contactable, we then have a local enhanced contact tracing service which will again contact those people and follow it up with a visit where they have not been contactable, and that's a visit to, one, to identify that they live there, two, to ensure that they're isolating with their family, and three is where it's required to link them up with our community hub and the financial support and the grant payments if they're eligible to it. And there are a number of people who are eligible. What we do see is a number of vulnerable families, particularly in houses of multiple occupancy, where linking them up with community services is actually a really positive way, which allows them to isolate, but also to safely isolate, and also have access to the basic essentials that allows them to do that. On top of that, Sam uses much of the graphs that you've seen this evening to be able to target where our enforcement team work. Our council enforcement works with the police, and just to remind everybody, our council enforcement deals with enforcement with businesses, and the police deal with enforcement where individuals are concerned. And our colleagues from the NHS and social care have been working systematically in terms of managing demand for hospital care, providing system leadership across health and social care to make sure that the care is delivered in the best place for individuals to get the best outcome. And obviously, as we've moved into a period where there are high numbers of people in hospital, making sure that the right care is given in the right place is been absolutely essential, because some of our resource is finite. On top of that, we have established forums within our community groups to support our care homes, particularly, and to ensure that right from the outset they have adequate access to personal protective equipment, and they've got access to infection control nurses and a designated GP. There's been respiratory hot hubs within primary care that's aimed to ensure that people are supported within the community, rather than accessing hospital care when it can be avoided. There is a fantastic discharge planning team that links all the system up to ensure that safe discharges happen, and significant work between hospital and community services that is flexing in order to manage this absolute massive increase in demand for NHS care. And on top of that, I think Ellie will come in a moment to talk about actually the way out. The way out is the vaccination plan. Now, whether it's a vaccination plan for this year, and as the Chief Medical Officer says, it may be that there have been various variations of this virus, which will mean that, like the flu vaccination plan, it becomes annual. We shall see. But actually, for here and now, getting the vaccination program rolled out with the ambition to vaccinate as many people as quickly as possible in order of priority, and to do it safely, is going to be absolutely key moving forward. So next slide, please. Sterling, I'll hand over to you.
Thanks, Kelly. So I am the Behavioural Insights Public Health Strategist in the Public Health team, and we'll just talk about some of the kind of insight, community engagement and communications work that we've done on the back of all the data and information you've seen before. So I'm actually going to talk about the bottom bit first before I move to the top, sorry. But using the data that we've seen about geographical infection rates and demographics and socioeconomic status, and that influence on the outcomes across infections and subsequent deaths. We've done a lot of different work using that data. So to start with, we've done a lot of work around the testing in general. So back in September, it was with the PCR mobile testing unit opening a second one in Heston when the infection rate was high. But lately, it's been more about communications and engagement towards those areas. But also, when we opened the asymptomatic testing sites, we started in Hounslow Central and in Heston, where our infection rates were consistently high across the past few months. So we also have used the data previously in the summer to think about kind of the diabetes work, so the impact of the first wave. How can we use a preventative approach to protect those who are most vulnerable going forward? So we did a big insight-led engagement program, testing some messaging, which led to Hounslow having the highest number of people enrolled in the Rewind intervention, which targets a small percentage of those people with diabetes and works to reverse the condition. So that was something we did successfully then, and lately we've been doing more of the work around kind of engagement work with the ECT, so enhanced contact tracing, to inform some of the work that we're doing and the engagement that we're doing. We've recognized that we have a high number of HMOs in the borough, as Sam showed you, and so we've written to HMO landlords and tenants to provide them guidance and information about kind of the testing offer and the test and trace program. Has also worked with knowing that most of our residents who are going out to work are probably still engaging with the kind of Heathrow network. So how can we work better with Heathrow to do those things? But we've also recognized that the communications we have been providing have been really well received by those who get them, but they're not getting to everyone in the borough. So we did a bit of a deep dive into how can we fix that. And like other boroughs, we launched the Community Champions program. So that is the aim of utilizing the voices of already trusted members in the community. So using it in a kind of circular approach. So using it to get messages out into the community, but also using it to get the messages back from those in the community. So we've launched the program in August and recruited about now 110 champions from really different groups and backgrounds, with a really, really diverse number of people, pretty much spread across the borough. We have a bit more engagement work in some areas to do, but, or at least for those who have provided their kind of general area, but we do have a general borough-wide spread with this. And we've been able to see the impact of this program in a number of ways. So when we've sent out a survey just to this group of 100 people, we get over 200 responses. So that means we're getting double the responses of the people that we're speaking to. We've launched a testing site on the day and just used the champions as a way to communicate that. And we saw the highest number of people attend that testing site. I think, if I'm right, that it was at that time in London at any of the MTUs. So it's been a really successful approach in reaching people in a different way, knowing that we didn't have that much time to work on building further trust or engagement ourselves, but we could utilize the connections and the strong sense of community that already exists in Hounslow to build on those messages, and to make sure that those people who are providing messages have the right kind of public health advice and guidance and understanding of the rules. So we provide it in a very simple, easy to share way, in an email that people can share in their WhatsApp groups. They can call their communities and speak to them directly, but that they have the right information to share. We've also engaged with the data around who's been most impacted in relation to different groups, and recognize that not only amongst different cases across ethnicities, but also amongst hesitancy and vaccination, our Black Afro-Caribbean groups are showing high levels of hesitancy and high levels of infection. And so we've run a focus group with a group of Black men, particularly last month, and we have another one on Thursday about vaccinations to further understand kind of the barriers and motivations that this group might feel about the vaccination and other health work. So we're doing a lot of work around just utilizing our connections to the community and utilizing their connections to further deliver messaging, and it seems to be working really well. So we're going to continue that approach going forward, both with improving the current services we have, so trying to think about how do we improve the contact tracing program that we have now, which will be most effective as the infection rate decreases, but also thinking about how do we encourage uptake among those hesitant people in the community who, and how can we make sure that they have the right information to make an informed decision about the vaccine. So that's a lot of the work we're doing now. I think our engagement work, we've recruited and welcomed a new member into our team who's really helping us to take this forward, and we've engaged with our champions kind of in casual catch-ups recently, and really gotten some really good feedback about the work that they're doing, and the amazing work that they're doing. You know, they're providing food to people, they're calling 40 people each time we send them an email, and directly giving the information to them for those who don't actually have access to digital smartphones or computers. So it's really making an impact, and I think we will continue to do this for wider determinants, not just around COVID.
Thanks, Sterling. Next slide, please. Ellie, over to you.
Hi everyone, my name's Ellie Tobin. I'm usually a Children's Joint Commissioning Manager, but have been redeployed onto working on the vaccination programme across the local authority and CCG. Next slide, please. So as Kelly said earlier, working on the vaccination programme has been a real joy, and it's a real sense of hope amidst what has been a really tough couple of months for the NHS and all public services, and frankly everyone. So as you can see from this, we have a really wide range of different options currently in terms of how we are rolling out the vaccination programme. So it's a real kind of multifaceted and group effort with regard to how we are reaching members of our community in order to roll out the vaccination as quick as possible, in line with the government guidance and in line with the Joint Committee for Vaccination and Immunisation guidance. So we have, first of all, we have roving vaccination teams who are going out from GP practices who have administered vaccinations to all our care home residents and staff, all those eligible, including extra care, and they've also been working on the housebound with district nurses support as well. We have 4 approved primary care vaccination sites, which span our primary care network footprint. So they are in Feltham, Heart of Hounslow, Chiswick and Isleworth. And each of those sites have the capacity to deliver approximately 350 vaccines per day if we're talking about Pfizer vaccines, and up to 400 to 500 if we're talking about the AstraZeneca vaccines, as you don't require a 15-minute wait after each of those, so you can get through more patient flow. We will also have a mass vaccination centre, and I've said it's due to open in February. It's been slightly pushed back, unfortunately, but we will also have access to a site near Heathrow. So between them, those sites will have capacity to administer approximately 6,000 doses per day once they are up and running, which is really promising, and that will massively increase our capacity. A number of community pharmacies are currently just coming on stream as we speak, which is really exciting. They're working closely with our primary care sites and with our CCG to help inform reaching out to some of our more vulnerable groups. And hospital vaccination hubs are also supporting with the vaccination of frontline health and care staff, which is really promising. So in terms of the order of residents to be vaccinated, we are following the national guidance outlined by the JCVI. This means in Hounslow, this is approximately 45,830 first doses that need to be administered by the 15th of Feb. This is via all of those routes above. So it's not just GPs that need to administer those, which will require on average about 1,500 vaccinations per day, 7 days per week. It's taken a little while for us to ramp up to that capacity, but we are now averaging approximately 2,000 vaccinations per day across all of our sites, which is fantastic. That's been the level we've been operating at for the past few days. And we have now administered more than 22,000 vaccinations since the 15th of December. They are first doses only, must be said, as we are acting in line with the national guidance with regard to the delay of the second dose. Next slide, please. So in terms of what those numbers look like in Hounslow, where are we at, or how are we doing? So we have completed, as I mentioned before, for all those eligible in a care home. So when I say eligible, because people can't be vaccinated if they've had COVID in the past 28 days. So that means that for those care homes that have sadly had outbreaks in the past 28 days, we weren't able to vaccinate those residents who had recently tested positive. So that has been completed, and then there'll be mop-up sessions planned in the future for the next few weeks for those who are coming out of that 28-day period who want the vaccine. So they'll be returning to administer vaccinations for them. Staff have also had vaccinations, and we had the highest uptake of care home staff vaccination in Northwest London, which was really promising, and one of the highest in London. We've completed, actually, as of today, we've completed 78% of our over 80s, which is fantastic. I completed this data yesterday, so it's always increasing, always improving, which is really promising. We've also completed all of our primary care, frontline health and care staff, and then our remainder, such as social care and all of our healthcare staff in our other NHS trusts, for example, are being vaccinated via hospital hubs and mass vaccination sites, and they are well underway. And making excellent progress. We know those that are NHS Trust partners as well are making really great progress with regard to large percentages of their staff taking up the vaccine. And then we are also now well into our cohorts for our, the priorities 3 and 4. So we will have sufficient vaccine in order to vaccinate the target. Well, the target is always 100%, but the kind of minimum achievable target is 80% uptake among all of those groups. So we have sufficient vaccine in order to do it. So we are aiming to complete that by the 15th of Feb. The next slide, please. There's just a couple of additional cohorts who you might have thought, why are they not outlined within this? So extra care staff and residents, so locations like Bristol Court in Hounslow, well, it's in Feltham, and a couple of other settings that fall under that extra care banner have all been vaccinated as well. And our other CQC registered care homes, we're referring to them as, so they are care homes for the those with learning disabilities and with mental health problems. They have also been completed as well, again with mop-up sessions planned. The housebound, as I mentioned earlier, have also been completed. So we've done the vast majority of the over 80s housebound, and that is rolling on now for the younger cohorts. So beyond the 15th of February, there isn't a kind of clear national directive yet, but we plan that we will just continue to be rolling out as per those JCVI cohorts, and we will respond to any changes that national government make with those, and that the JCVI inform us that we need to do. And obviously in the next couple of weeks we'll be starting out on delivering second doses for lots of those who were vaccinated in the last couple of weeks. So we'll be kind of rolling back around with that. With regard to challenges to the programme so far, the main challenge has just been with regard to vaccination delivery and supply. So we haven't been able to dictate how much vaccine has come to Hounslow and where it's going to, which means that some areas receive vaccine before others. So we've been working really hard to make sure that we're able to try and balance that out and reduce any health inequalities. And going forward, we're going to make sure that we're trying to come up with some creative solutions between partners about how, between the council, CCG and other partners, BCSE for example, we can work together to make sure that we are reducing vaccine hesitancy, and also reaching out to some of our more vulnerable cohorts who may be more reluctant to receive the vaccine, and engaging with them more closely on that. That's everything from me. Back to you, Kelly.
Thank you. Next slide, please. I'm just sort of aware that one of the things that I'm really keen to just mention is that public health isn't just about infection rates, deaths, vaccine coverage, and testing. It's much greater than that. And what we've tried to do today is just focus on part of the response. So we haven't really presented sufficiently in terms of non-COVID activity, what the implications are for all of those people that should have been coming to health services who haven't over the past year. We haven't covered areas such as mental health. We know that that is a burning issue that is going to have to be picked up. We haven't talked about the impact on education opportunity, employment, and all of those contribute to significant health and social inequalities. And actually, just to really reinforce that we know that coming out of the back end of this, and I think Sam, you mentioned it, is that the people that were already there was already a disparity in health and social inequalities will come out of this with a more significant gap in terms of inequalities in health and social and economic. And these are the things that we know that we need to drive forward. So we've talked about a little about what we've learned, what we've done that's different, and how do we then apply it to our current priorities, because it's a so what factor. So we know that tackling health inequalities is an absolute must. We spoke about at our November meeting that there was a recovery plan that had been put together as part of the response to the first wave. I'll just remind you in a second what we discussed on that. There are clear pre-existing inequalities within our borough. I'm not going to shy away from the fact that all of the things that Michael Marmot said in 2010 and he reinforced in 2019 when he reinforced his arguments about inequalities across all life stages, those were already there. What this has done is shown an absolute spotlight. COVID has just made it very obvious that these disparities exist within our community, within our different communities, and geographically as well across our borough, depending on where our communities live. And that's shown in our data, and it's also shown in the Public Health England report that was produced in July that talked about disparities in an outcome with COVID, and really focused on BAME communities in particular. When I hope that that particular publication is updated with new information, all that will do is show an even bigger gulf using the data than what existed before. But it's really important when we think about how do we apply this to our current priorities, and also in consideration for the next agenda item, which is what's our role as a board, to think about what are our current priorities and how do we move this forward. So what's clear is that there is various work streams that are dealing with COVID-19. It was some of which those work streams were already pre-existing work streams which are already recognised what the health inequalities were. And as I said, all we've done here with COVID is shone a spotlight on them. They're already there. They're just bigger and just more obvious now. We've got one borough population, okay, and essentially their needs are essentially, regardless of which work stream, which program of work we're dealing with, their needs are exactly the same. So moving forward and how we work and operate within the system that we currently have, we need to be looking at how do we add value? What are the synergies between the different statutory and non-statutory work areas that we've got, and how do we work together, because there is plenty of work that we need to do in order to address this. You know, as the chief medical officer said, this is something that we may have to learn to live with, but we need to get on top of it and be on the front foot rather than constantly being reactive to this. So our current drivers that are working on tackling health inequalities is our integrated care partnership vision work plan and the work streams that are associated with it. And Pauline's going to talk about that. Our council corporate plan that has been published in 2021, which talks about a fairer, greener, stronger borough, and how we will work together to deliver that. And that kind of looks at the wider determinants of health, because obviously, as Sam has presented in the data that he has, people's living conditions, their opportunities, the opportunities that they have throughout their life course clearly impact on their health, their well-being, and you know the risk factors, the jobs that they're in, their exposure, and a whole host of these wider determinants of health that actually certainly as a council we're all working together to address. And as I said, in November we looked at the recovery plan, and this is a part of the work that we have been starting to deliver within the Health and Wellbeing Board. We said that we were going to do a forward plan, and the Children's Delivery Group has taken forward the children's element of that. In November 2020 meeting, we also talked about reviewing the health and wellbeing strategy. And so what are the next step, Councillor Bath, I think Councillor Atherton is on the meeting as well, is to look at what did we just remind ourselves what we said were the priorities from our recovery plan. Pauline's going to talk then about the integrated care partnership and how the integrated care partnership is also looking at part of those health inequalities and how we're addressing that. And then Taru is going to come in the end, because she's going to support me in leading a review to look at the role of the board in delivery of our revised strategy, whatever that looks like in terms of the synergies we have with those other elements of the system that's working together, and to start a consultation on what our terms of reference could be and what we need it to be for Hounslow. Next slide, please. Next slide. Lovely, thank you. So our recovery plan, just as an aid memoir, our outcome one we said would be a system-wide action to address health inequalities, reduce disparities in risk and outcomes of COVID-19, and respond to subsequent waves. Now, clearly, when that recovery plan was put together back in September, we were anticipating wave 2. We knew that it was likely to coincide with winter pressures. Perhaps what we were unclear about is what the impact of it has been. Clearly, we're on the back end, certainly in the community, we're on the back end of the second wave. I think the hospital would say that they're still in the thick of it and will be for the next few weeks. But certainly, I think some of the things that we said as part of that recovery plan have come to pass. So we talked about targeted action to reduce disparities in risk and outcomes for groups and communities. We've seen that in the data, that some groups are more adversely impacted than others. And we needed to focus on lifestyle services, addressing diabetes, looking at obesity, healthy weight management, and to look at avoidable ill health during winter. I'm not sure that we've entirely got on top of that one. And we talked about a new model for healthy lifestyle services that target the rising risk group. And that's certainly a work stream that's really been pursuing diabetes, hypertension, and various of those significant long-term conditions that have most Excuse me. Apologies, this is my computer's not declining the call.
Okay.
um, Outcome 2, we talked about our services being outcome focused and investing in prevention and early intervention, health education, support to empower residents to self-care. Now, given what we've seen in terms of, if you even just look at the language barrier and the communications, I think part of our work with our community needs to rethink how we're going to do that, how we're going to deal with different communities, because one size clearly doesn't fit all. And we did talk about effective use of local data. That started to play out through our population health management program, but and certainly the data that we started to use as a system in terms of how we look at the impact of COVID, targeting and interventions to different communities, greater engagement, evaluating the effectiveness of our intervention to reduce health inequalities. I think we need, this is a massive piece of work that we need to do going forward, because every time we will get a subsequent wave of COVID, the same people are going to be impacted. So we need to deal with this at pace and ensure that our services are being responsive to this. Next slide, please. Pauline, I'm going to hand over to you to talk about the ICP program and how that links into the work that we've just been discussing.
Sure, thanks, Kelly. So just for anybody who doesn't know me, my name is Pauline Mason and I'm the Integrated Care Partnership Program Lead in Hounslow. So what I want to do is go through this really quickly, because actually Taro's section, which is next, which is talking about the role of the Health and Wellbeing Board, is really linked in with this actually. And I think it's almost the more interesting bit. So really, who is doing the slides, we're on this bit. So is it the most important bit to know about, sorry, if you go on to the next slide, please, to know about this is that the strapline that we have here about our communities being healthy, happy, connected, and able to realise their full potential has been taken. You'll recognise this from the Health and Wellbeing Strategy. And as a group of leaders and chief executives and senior exec directors from the range of partners that we have within the Hounslow ICP, we agree that that is the most important part of our vision. And then the line that you see beneath that about providing care and support based on people's needs and preferences is how we want to do that. And in that, the ICP is sort of the vehicle for delivering all of this. So on that slide, you'll see some design principles, but what's been really important for us as partners is to establish some key behaviours about how we relate to each other. And those are things like empathy towards colleagues, sharing challenges, taking collective responsibility, and being supportive and asking for help. So if we move on to the next slide, please. So the next slide is about the difference we want to make to our residents. And this is about being supported before a crisis, feeling listened to, feeling connected. And all of these are taken from many years of different pieces of work in Hounslow, going out, talking to residents, future-proofing health in Hounslow being one of them, for example, to see what people really, really want from a joined up health and care system. So next slide, please. And what we've also found really important for us as part of the ICP is that equally as important is understanding the difference that we'll make to our staff, so the staff feel that they are connected, informed and empowered, and that is absolutely driving what we do. If we move on to the next slide. This sets out our population challenges, and all of this will be really familiar to all of you sitting on the Health and Wellbeing Board. Probably the thing that we really focus on as well within the ICP is that there is also shared challenges across partners, such as workforce gaps, financial pressures, and this delivery of kind of varying and fragmented care and often duplication of services. Next slide. So this is just coming back to the bit that Kelly mentioned earlier about the Hounslow Recovery Plan. So this Hounslow Recovery Plan, which has got the recovery efforts focused on the 4 key areas, and in particular the tackling and local inequalities, supporting local residents. The ICP, which is chaired by Niall, the Chief Executive of the Council, and by the HRCH Chief Executive as well. The ICP we see as the vehicle to help achieve the vision that I've set out, but also to deliver some of Hounslow's recovery plan too. And the next slide will show what we describe as our building blocks to integration. And this is about our offer as a place. In the next section, Tara is going to describe the difference between the integrated care system and the integrated care partnership. And we in Hounslow have an integrated care partnership, and that's what we refer to as place. And so in this, sat at the top, we've got the Hounslow ICP Recovery Board, which I mentioned just now about the chairs. And our offer as a place, whilst there's lots of things going on, we can chunk it up into 5 things. One of those is primary care, and how all of our units are delivered around those localities and primary care networks. Then there's mental health, and how mental health delivery will be woven into primary care. Our home first model is about keeping people at home for as safe as long to do so, or as clinically appropriate as long to do so. And we're focusing particularly on people with frailty, dementia, and end of life care. We've got Community Solutions, which is a program being delivered through the council and also working with the voluntary and community sector. And there's children and young people. And underlying all of this is the bit about tackling inequalities and pooling our resources to do so. And then the next slide, basically the next slide, and why this is of interest, and a really just literally for about 10 seconds shows the governance that we have. So we've got, these are the work streams that helps deliver the building blocks, which report up into the Integrated Care Recovery Board. And what we have set out here is that as well as reporting into the North West London ICS, we also need a line into the Health and Wellbeing Board. The discussion that Tara is going to talk us through just now is going to be about what that relationship should actually look like, and whether it's an accountability function, whether it's a reference function, what that should look like. And that's what we're really interested in kind of hearing from you guys, basically. So that's me done, and I think Taru's next.
Excellent. Thank you so much, Pauline. Wow, so you've got a lot of information today, really. And I guess my job now is just to kind of weave these bits of the story together. So really, you've heard probably 3 main things. One is that the way the COVID has changed our borough, really, and our operating context has changed, but also our strategic focus in order to react to these changes has changed. And my question really for you, rather than anybody else, is what does this mean for the board, and how do we take this forward? So next slide, please. Okay, so this is just a bit of background information, and it's probably like sucking eggs for you, but you'll remember that Health and Wellbeing Boards was established under the Health and Social Care Act. And I want to kind of really emphasize that the role and function of health and wellbeing boards at this point of time isn't very clear. NHS England suggests that there'll be some kind guidance will be developed, but it really is up to a lot of health and wellbeing boards to kind of forge a path for themselves in trying to make themselves as much really purposeful in this kind of new operating context and within the health system as a whole. So like I said, the health COVID has changed our health landscape. The ICS, Integrated Care System, and the Integrated Care Partnership, which Pauline was talking about, has also changed our operating context. So we've got different structures and new relationships established, and we really need to respond to those. And I suppose in general good practice, like any board, we would be reviewing our terms of reference as part of an annual review. And then, as Kelly mentioned earlier, we've made some promises in our recovery plan that as a borough that we would look at our health and wellbeing strategy and ensure that it is really strategically relevant for our new context. At the same time, internally, we've got a corporate plan that is going to council at the moment. It's just a refresh in the context of recovery. And there's also processes at the moment that we're going through to review our constitution, which is slightly out of date, to bring it up to date. So this is a really good opportunity for us to think about the role of this board and also its relationship to, like Pauline said, the Integrated Care Partnership Board, but also other boards that exist, the safeguarding boards, our Community Safety Partnership, and how do we, as partners, interact with those boards. And I think there's also a really exciting opportunity, which Sterling's touched on, in thinking about the way that the a health and well-being board might champion and enable better engagement and consultation around health and well-being and the broader determinants of health. We've got some really concrete examples of how communities have stepped up to look after each other and help themselves, and how do we take this forward and build off the wonderful work that's happening in our communities. So this presentation is really a process presentation, which feels a bit boring after all the information that you've received. Just setting out what we could do next to make this board as effective and purposeful as needed in this new context. So next slide. I'm just going to whiz through this. This is just, and you can look at it in your own time, the statutory sort of back to basics of health and wellbeing boards. Why do we have them? What are we supposed to do? We have obviously our sort of statutory duties, but I think the way that the legislation and the guidance talks about health and wellbeing boards is really that we should respond to the wider social, environmental, and economic factors that impact on the health and wellbeing, and really work in partnership with our partners across the voluntary and community sector. There's also a bit in there about what statutory membership would look like, so we'll be having those discussions as part of that process. Next slide. Okay, so this is just a summary of your current terms of reference, in case you haven't got a chance to look at it. It tells you what the main aim, which is really bringing together the leadership of key organisations to plan and work in partnership, identify local needs, inequalities, monitor performance, and develop effective plans and services. We also, beneath this Health and Wellbeing Board, have a children's delivery subgroup, which Kelly was talking about earlier, and a health integration subgroup, which kind of really, in the context of what's happened in the last year, has probably become not as relevant as was before. So this is just an opportunity to kind of review the whole structure. Next slide. Okay, so this is just a recap of what Kelly, Sterling, and Sam have been telling you for the last hour or so. Basically, our borough has changed, and beyond the clinical impact, there's been a massive, broader impact on our borough, and this has not been felt equally across the borough. So that's just a 30-second summary of what I've heard come out of this meeting today. Next slide. And I suppose what Pauline was speaking about is that we're operating in a new context. And I mean, I'm not going to claim that I know much about the ICP and the ICS, and that's really Pauline's side. But really, if you look at the diagram on the left-hand side, we're really working at that kind of place-based level. So our thinking really needs to be about how do we create a place-based partnership and support and work with the existing structures. Just to say, I have set out the guidance that's come nationally about integrated care systems and the relationship with Health and Wellbeing Board, but it really is scant. So I think there's a really amazing opportunity for us to think about how the Health and Wellbeing Board can place itself within this context and think about the best way that it wants to work. As Pauline's mentioned, we have an ICP board that is co-chaired by our chief executive, and it's this relationship that we want to work through and discuss in the next few weeks. Okay, so it's next slide. So this is how I'm proposing we do it, and it's a really simple slide. Basically, we're operating in a different context, which I think you've heard a lot about today, and it's an opportunity for us to refine the role and focus of the board. So what is the best, most purposeful role for this board, and what should our focus be on in this new context? So rather than kind of separate out the sort of governance arrangements of this board and the strategic aspects of this board, it really is in some parts one and the same question. So the session is for us to have a series, or the proposal is rather, for us to have a series of workshops and engagements to discuss the role of the board and where we think we'll be taking it forward. So we're asking questions such as what works, what doesn't work, what are the opportunities available for effective action, where should we focus, what are the alternatives, what are we seeing as effective board action, like Pauline said, what are the relationship with other boards, and can we think about the Health and Wellbeing Board as a key engagement forum or other such innovative mechanism. And then what will we get out at the end of it? Well, we'll have a new terms of reference and a refreshed strategic focus for the board. So this is as Kelly mentioned, an opportunity for us to think about our forward plan, but also for us to think about the health and well-being strategy and what this looks like in our different and new context. The timeline for this is really starting from now up until May, when we hope to have this all finalized. And the process is really up for discussion and debate with the board members, but we're hoping to engage you in small workshops and, if possible, kind of small group discussions to just understand your views on how we might make the most of the role and purpose of this board. And that's me.
Okay, thank you, Taru. Can I just check? I'm assuming you are going to suggest some workshops for this particular proposal.
Yes, Chair. If you if you like it, I'd love to. So
Yeah.
it's just really getting your agreement that this is the process that you're happy to go through, and then we'll be engaging with you to set up some convenient workshop times.
Okay, that's lovely. Thank you. Can I'm happy with that. I'm happy to take questions, but just before I take questions, I just wanted to thank Kelly and the team and everyone for all the hard work that they've actually done. I mean, it's quite staggering in terms of the amount of information that we've got since the first wave of the pandemic, and we're getting more and more information, and we're getting a really good picture. I mean, you guys, in terms of all the work that you do, must be absolutely exhausted. You know, but it's amazing the information that we've actually had, and it's quite clear from all of Kelly's presentation and all the slides that we've seen today that obviously we have some real health inequalities that are quite staggering. And obviously, I mean, personally, from my perspective, I think the board is obviously we're in a completely different place to where we were some time back, and I feel the role of the board is going to be really prominent and really important in terms of moving forward and recovery. But I'm aware of the time. We've had some really excellent information, and I think it's quite clear in terms of what the story is and how we propose to move forward. Does anybody have any questions or comments that they want to make at this stage before we kind of think about winding up? And I'd just like to welcome back Councillor and Candice Atherton as well. Welcome back. I know you've had a traumatic time, but you're back with us. Candice, do you want to come in?
Thank you so much, Councillor Bath. Yeah, also I'd love to echo your words. Like, it's just incredible to just be able to get all that detail, and we have all this understanding. We've learnt so much over the last year, you know, and now we're sort of back in the sort of the thick of it all, and you know, we're able to like see things from a completely different perspective. I remember when I met with Kelly in the weeks or months when she first joined, just before the pandemic broke, and Kelly had a big vision around tackling obesity and really looking at social determinants of health associated with obesity. So yeah, it's really just good to know that we are, you know, able to sort of get back on track of looking at everything through a very different lens, but a lot of the things that we already knew. My only thoughts around the workshops and going forward, I just wondered how much because we are going to be so much more focused on social determinants of health, I just wondered how much we're going to engage. I know we've got a much closer relationship now through Councillor Bruce with education, but will we also be engaging around housing and sort of economic kind of social determinants of health? So I just wondered, will we be sort of broadening who can come to those workshops, who can contribute, etc.?
Kelly, did you want to?
Yes, please. Well, health in isolation doesn't. There is no such thing. You can't improve health without thinking about all of those wider implications, such as sort of a parity with mental health, what drives mental well-being. That's also about the social determinants of health, the economic impact. Clearly, there's going to be significant disparities between the haves and the have-nots. And as we know, the have-nots are going to have even less. We need to look at employment. We need to bring in housing. We need to bring in sort of access to sort of the environment, all those kind of social determinants that actually contribute to well-being. In fact, as a council, everything that we do, regardless of the department that we work in, contributes to that. So I think we just need to start recognizing that health is not just about health services, and as a board, that our whole play space is absolutely key, and that it's much wider than the services that we offer, whether they're preventative and they intervene early, or they're responding to ill health as it exists. So it needs to be bigger and better.
Thank you, Kelly. Kelly, can I just check, just ask you, is there, obviously with all the information that you provided today, and I know that as time goes by, we will get more information, won't we? And I'm particularly interested, I suppose, about the communities out there who are getting COVID and who are being affected seriously. I know that BAME communities are disproportionately affected, but I at some stage I'd quite like to have a little bit more granular information about workforce and how they live, etc. And I know that is it's not something that we can get very quickly, but I hope to get a clearer picture at some stage. So that would be really helpful, because obviously then we know how we target our work. But I just wondered from your perspective, Kelly, I know we've got a number of people on the line about what the board can do, or what people here can do in terms of our membership. I mean, apart from obviously promoting the message of vaccination, which I think we appear to be doing very well, but is there anything else that we can be doing as a board, apart from the fact that I think we will be focusing on this for a long time to come, won't we? This will be a priority for us, I think, in terms of the board. But I just wondered if there's anything specific that you could get the board to help with.
Yeah, I mean, I think our strategy needs a complete review. And going back to the slide where I said that we have one population, it has a specific set of needs, and there are different needs within different communities. So I think we need to be more savvy about, when we talk about sort of our strategy being every child in Hounslow gets the best, as good a start in life as it can do. I think we need to be really understand what does that mean for us as a borough. And I think sometimes the strategic headlines need to be met with some clear sort of interventions that are absolutely going to make an impact, and we're able to evaluate that. So I think as a group we need to be a bit more strategic. Some of the things that perhaps we have brought to the table are a little bit operational, and I think we need to certainly be able to task different groups to be able to go away and do the work rather than do the work in the forum. But Pauline was really clear, is that the ICP clearly has work streams that are aligned and has synergies with the work that we do. We need to be able to differentiate what it is that we're doing so it aligns with rather than duplicates with. And I think trying to identify where we exist in the kind of governance structure, given that there is so much work to do, and having really clear strategic direction is going to be absolutely key moving forward. But as I say, dealing with health inequalities is a big ticket item. It's not going to change overnight. It's going to be in the course of many months, many years, to try and affect that change. And actually this board needs to be have representatives from across the system, from across all of the departments, regardless of the organisation, that contribute to making health and well-being in its widest sense. Again, not just about health services. Health services only account for roughly about 20 to 30% of health. It's the life people live and their access to things that improve their life, such as education, such as access to good food. That all contribute. It's very complex, and I think we just need to recognise that it's not just about a single issue. It's about bringing together a whole complex problem or series of problems, and how we work together as a system to address it in a strategic way.
Thank you, Kelly. That's very helpful. Tara, I know we kind of have covered your agenda item, haven't we, in terms of governance of the board. Is there anything in particular that you want from today in terms of a lead moving forward?
Thank you, Councillor. Not really. I suppose I need you to agree that you're happy with the process, and it sounds like you are. So what we will do is circulate some dates to members and hopefully give you a few options for different workshops and engagements, so that we can get something together, and then also come back to this board for your next meeting with some of the initial thinking and perhaps a draft if we can get that far after the workshops.
Okay, that's great. Thank you very much. Then moving on to next item agenda is any other business. And I haven't been informed of any other business. So unless anybody's got anything, I've just got a hand up from Charanjit. Did you have a question to ask, Charanjit?
Yes, I do. Thank you. Today I received through my letterbox, I hope you can all see it, it's signed by Kelly and of course the leader of the council, the letter about high COVID-19 rates in Hounslow and Heston, with lots of translations attached, the letter and the different translations. I happen to know and read very well both Punjabi and Hindi. And I think it's a great mess up. I'm sorry to say those words.
Sorry, when you mean a mess up, the translations don't make sense?
The translation itself it's very, very difficult to read. There are spelling errors, there are grammatical errors, there are things which are not very, very clear. So what I'm saying is that the purpose of informing people in their own language so that they can understand what the whole issue is probably not being delivered. I'm sorry.
Can I just ask you? No, that's fine. I mean, can I just ask you, is there a particular language that you feel is not being translated?
Well, I have read both Hindi and Punjabi.
Okay.
It's on the basis of that I'm saying that.
Sure. Well,
could I
take that
in?
away? Yeah, Sterling, you've got your hand up.
It's just to recognise that we've realised that this week as well. So we saw some other translations that we stopped from going out, and that one had already gone out. But we recognise that that's an issue we're having, even though we've used about 3 different translation companies. So we've asked our head of comms to go to London comms to get feedback on which companies are actually good, because everything we've had the same exact comments on, and we're trying to utilize the community champions.
I think what I'm going to say is that you need a very simple language, not academic language.
Okay.
For people to be able to be understanding that. And not only that, correct spelling for once.
Yeah, we're working on it. We absolutely recognize it, and it's an issue that we're trying to solve. So apologies.
Okay, thank you for that, Charanjit. So we need to work on that. I'm just looking at the chat, and I think we've had a similar comment regarding the Polish translation. So we would probably need to look at all of the languages and make sure we've got the narrative right. Okay, so can we take that away as a piece of work to have a look at, please? Thank you. Any other questions? Thanks for raising that, Charanjit. It's really important. Any other questions or any burning comments that people want to raise? I'm just aware that it's 6 minutes past 6. Candice, you got your hand up. Yeah.
Only to thank you, Councillor Bath, for taking on the chair and without any notice. Thank you so much.
That's okay. Yeah, thank you very much. I was a bit unprepared because I didn't have all my screens and everything, but I think we've kind of stumbled through.
Really appreciate it, and sorry everyone that I was not here.
That's okay. Well done for making it anyway. I know you've had a traumatic time.
Well, I've had a good experience of the NHS. I've left Ben there, but I think he's going to be well taken care of. So
yes, he will. I've had quite a lot of experience of the NHS in the last 2-3 weeks, so it's all been really positive. But can I just say thank you to everyone on the call. Thank you to Kelly and the team. I mean, you must be exhausted. You get an absolutely amazing presentation with so much information that I've found really helpful. And I'm assuming that people can access this, presumably, Kelly, online, the slides or information like that. Is that all available? I guess it's available on the Health and Wellbeing Board website. But yes, it is brilliant. Okay.
Yes, it is, Councillor.
All right. Thank you very much. In that case, I don't have any other business, so I want to say thank you, everybody, and have a very good evening, and see you soon. And well done for all your work, everybody. Thank you. Take care now. Bye bye.